Hello and welcome to the Eurofins Transplant Diagnostics presentation, Managing Transplant Patients During an Epidemic. First, I would like to introduce Dr. John Friedewald. Dr. Friedewald is a professor of medicine, nephrology and hypertension, surgery and organ transplantation with Northwestern Medicine. He will present an overview of TruGraf. Welcome, Dr. Friedewald.
It's a pleasure to be with everyone today, coming to you from Chicago, wherever you are in the world. Thank you for joining us. I'm going to provide an overview of the TruGraf test. I have the following disclosures. I'm a clinical advisor for transplant genomics, and I have grant funding from Eurofins Viracor. So what is TruGraf? TruGraf is a test that was designed with a very specific purpose. Some tests are born looking for a disease, I like to say, and others, we start with a specific disease and develop a test, and that's what we did with the TruGraf test. So TruGraf is a blood gene expression profile test developed very specifically to detect the absence or presence of subclinical rejection in kidney transplant recipients who are otherwise stable. What is subclinical rejection? Very important to define the clinical phenotype. We define subclinical rejection by three things. Number one, normal renal function, and we chose a cutoff of 2.3 milligrams per deciliter below that as normal kidney function, and there is nothing magic about that number. We chose it because we wanted to be inclusive of patients who maybe had a higher level of serum creatinine, but otherwise a stable and healthy graft, perhaps due to donor disease. So we chose that number. Number two, stable renal function, defined by a change less than 20% from prior values. And number three, rejection on a surveillance biopsy done just to check the kidney for subclinical rejection. So those things define subclinical acute rejection. And we did a study to determine this. It was the CTOD-8 clinical trial. And in that study, we did two things. We developed the clinical validity of a novel blood-based biomarker for subclinical rejection following kidney transplant. We also defined the disease itself. So in a large multi-center trial here in the US, we defined the frequency and the importance of subclinical rejection. Critically, that even borderline rejection are meaningful in terms of clinical endpoints. Now, that important finding was found in our clinical trial, but it was also echoed in several other publications in the same year. So the group from Pittsburgh has published this, and actually a more recent paper looking at, again, early graft inflammation on protocol biopsies leading to poor clinical outcomes. And I'll show you what those are. Number two, a group from the University of Alabama, Birmingham, in a pediatric population looked at early rejection, subclinical rejection. And this group I'll show you later actually showed that treating subclinical rejection improved outcomes. Number three, the very large and well-designed GO-CAR trial, similar to the CTOD-8 trial, did surveillance biopsies in a large number of patients in the first 2 years and found, again, that subclinical rejection associated with worse clinical outcomes. And finally, the group from Australia published a similar paper, again, showing that low-grade inflammation in the kidney leads to bad outcomes. And so detecting this inflammation early and treating it is a key goal to improving long-term graft survival. So how often does subclinical rejection occur? We found in the CTOD-8 trial, and this was very similar to the GO-CAR trial, where surveillance biopsies were done at 3, 12, and 24 months post-transplant. And we found the point prevalence to be fairly similar at all those time points. So 20% of patients biopsied at 3 months had subclinical rejection, 25% at 1 year, and 25% at the 2-year mark. Overall, if you look at a subject level, because patients could have more than one biopsy showing subclinical rejection, 35% of patients in the study had at least one biopsy with subclinical rejection. And when we broke down the type of rejection, most were cellular rejection, T-cell mediated, and most were borderline. 70% were borderline rejection. 30% were either 1A or greater or antibody-mediated rejection, or some combination of those. So I mentioned it, but what are the consequences of subclinical rejection? Why do we care? This shows why. So we know from both the CTOD-8 and the GO-CAR trial, as well as the other trials I mentioned, that there's a higher risk of going on to develop clinical acute rejection after an episode of subclinical rejection. Patients who have subclinical rejection are more likely to form de novo DSA, statistically significant. They're more likely to lose the graft at 5 years, and that's shown here in the GO-CAR trial, where patients at the 3-month biopsy had no acute cellular rejection versus those that did, and this is subclinical, though those that had rejection had a worse graft survival at 5 years. They're more likely to develop fibrosis in the graft, grade 2 IFTA or greater, and that was shown in the CTOD-8 trial as well as the other trials, and a more rapid loss of GFR. And we've now followed our CTOD-8 patients out to 5 years, and we see a steeper drop in GFR, decline in GFR in patients that had early subclinical rejection. So all of these things together, of course, are early harbingers of graft loss and worse graft outcome long-term. And so we really need to focus on the early events going on in the graft to prevent those from happening. So now we know also that treating subclinical rejection improves outcomes, both subclinical antibody-mediated and T-cell mediated rejection. And this is one paper from the group at University of Wisconsin showing treating subclinical antibody-mediated rejection improved outcomes. In this study, they were looking at just donor-specific antibody development and doing biopsies based on that biomarker. And what they again found is if you treat early, the outcomes for those early treated patients are very similar to those that did not have any rejection at all. And I mentioned the group from University of Alabama, Birmingham, and pediatric patients treated pediatric patients with T-cell mediated rejection, primarily subclinical. And again, the treated subclinical rejection did better than those untreated. And so there's evidence both now for cellular and antibody-mediated rejection, subclinical, that treating improves outcomes. So let's take a step back and talk about how do we discover a gene expression test? What is that? The way we did this in the CTOT-A trial was we took a number of patients who had biopsies, 530 biopsies, all paired with blood samples. So we knew what the clinical phenotype was based on the biopsy. Then we looked at the blood samples of those patients. We had 400 patients who had a normal biopsy. We call that transplant excellent. And that's, again, stable renal function, normal renal function with a negative biopsy. And we took those that had subclinical rejection as previously defined. And then we looked at the differences in gene expression in those two groups by looking at an Affymetrix gene array. This is a whole exome array. We then filtered those genes by a bioinformatics process, and we used a random forest model that asked the question, what set of genes best tells these two groups apart based on their differential expression at that time point in the blood? It turns out the TruGraf gene expression profile consists of 120 genes that are either up or down regulated and specifically chosen to distinguish stable biopsies from those with subclinical rejection. So again, this is a very specific test for this disease, and that's important. The TruGraf test has been validated in external cohorts. This is a publication from Chris Marsh and colleagues looking at 7 US transplant centers who use the TruGraf test in the setting of patients that are stable and being biopsied. The accuracy of the result of a TX or a normal result was very accurate across the different centers. And you can see the performance was the same as in the CTOT-A trial, a high negative predictive value about 89% and a positive predictive value of 48%. So again, the TruGraf test is very good at ruling out subclinical rejection and knowing that a patient doesn't need a surveillance biopsy, that you can do without it and know they're stable. I'm going to move on to a few examples that illustrate how the TruGraf test can be used. And in these slides, I also have data from a cell-free DNA assay called the TRAC assay. And the way this works is this is a single patient. This patient was followed for 2 years in the CTOT-A trial. Patient had serial biopsies shown here along the bottom and TruGraf testing here. And you can see at 3 months and on the other time points. Now, the TruGraf testing in the study was not available at the time of the clinical trial. So the patient was treated based on biopsies alone. We then went back after we discovered the TruGraf gene expression assay and looked at what the TruGraf assay would have shown at those time points. And you can see this patient, the serum creatinine is shown here in orange. So a fairly normal, good, stable creatinine out to 3 months. But at 3 months, the patient had a non-TX TruGraf result, which means an abnormal result. The biopsy just showed interstitial fibrosis and tubular atrophy grade 1, but no rejection based on the biopsy read. Now, at that point, following that, the patient's creatinine started to creep up. At this point, at 6 months, the patient had a 4-cause biopsy. And again, TruGraf is not indicated currently in the setting of graft dysfunction, so a TruGraf test was not done at the time. The patient went on to have a BAMF2A acute cellular rejection. Interestingly, they also had thrombotic microangiopathy. And when we look at the cell-free DNA assay, which is positive above 0.7, you can see the cell-free DNA was going crazy. What we know about cell-free DNA is it's very sensitive to, very specific for vascular injury. And obviously a thrombotic microangiopathy, there's a lot of endothelial injury releasing a lot of cell-free DNA into the circulation. And so the cell-free DNA was off the charts. Again, this was obtained retrospectively. We didn't know it at the time. The patient was treated with steroids. And because of the thrombotic microangiopathy, they were also treated with plasmapheresis and IVIG. They were given antithymocyte globulin, and their tacrolimus was discontinued, thinking that was contributing to thrombotic microangiopathy. The patient improved, the cell-free DNA improved, and the TruGraf test went back to TX after treatment of rejection here. But again, a month later, a follow-up TruGraf test, and I'll show you the value of follow-up testing after a rejection episode, the TruGraf is back to being non-TX. The The creatinine went back up again. Another biopsy was done showing borderline acute cellular rejection and persistent thrombotic microangiopathy. Interestingly, at this time, the cell-free DNA was down now at a very low level. The patient was treated with anti-C5 therapy. Serum creatinine stabilized and continued to improve over the time. At the 1 year mark, the patient had another non-TX TruGraf result, and again, just showed interstitial fibrosis and tubular atrophy. They then went on to have 2 more TX results later on, again with the stabilized serum creatinine. But at the 2 year mark, they had a non-TX TruGraf result, again a biopsy showing borderline acute cellular rejection, treated with an increase in maintenance immunosuppression. So you can see how the TruGraf testing can mirror what's going on in the biopsies and eventually replace what we need for biopsies in stable patients. This is a patient who had subclinical acute cellular rejection, which eventually evolved into antibody-mediated rejection. And I wanted to show this case because I think when we think about how this happens in an individual kidney graft, we have an early cellular response, which then leads to a memory response and antibodies. And this is a great example of that. So this patient, again, had an early course that was very good. And if you, again, look at just the patient's serum creatinine, it was normal throughout the 2 year trial. So if you just were following serum creatinine, you might see that this person was doing totally fine. At 3 months, they had a normal biopsy and a TX TruGraf result, so potentially they could have been spared that biopsy. By 1 year, though, the TruGraf test is non-TX abnormal, and we find borderline acute cellular rejection. Now, at the time, it was clinician preference in the trial. It was not an interventional trial. The clinician chose not to treat those borderline infiltrates. But what we know is those borderline infiltrates, when they hang around for a while, can lead to ongoing immune response. And sure enough, by 15 months, the patient goes on to have, again, a non-TX TruGraf result, a biopsy done because they developed some proteinuria, and they're found to have borderline acute cellular rejection, which is persistent. And now they develop the antibody-mediated rejection and a new de novo donor-specific antibody. At that time, also, the cell-free DNA is positive at a level of 1. The patient's treated with steroid pulse, IVIG, and rituximab. You can see the cell-free DNA, which was tracked, went up to 8 and up to 10 eventually. Now, some time goes by. At the 2 year mark, they have another surveillance biopsy with, again, stable serum creatinine. The TruGraf is still not TX abnormal. The biopsy still shows AMR. Cell-free DNA is high, and they're treated again with another round of steroids, plasmapheresis, and IVIG. So again, showing a lot can be going on with stable serum creatinine that you'd be missing if you weren't looking deeper, either with biopsies or with biomarkers. And the message here is that biomarkers can often spare patients biopsies when they don't need them, or indicate when they're needed and to diagnose disease early. Here's a patient that was a highly sensitized patient who underwent pre-transplant desensitization for an HLA positive cross-match. I just want to illustrate this because this shows how, again, gene expression profiling like TruGraf can work in conjunction with cell-free DNA. So again, this patient early on, again, had a perfectly good course in terms of their kidney function, very stable and normal serum creatinine throughout the 2 years. But again, if you dig deeper, you see that cell-free DNA, which is normal at 3 months, is up by 6 months above normal. And then you have a spike here by 9 months, but because the protocol was stable kidney function, they only had a biopsy at 12 months. At that time, the TruGraf test is abnormal, not TX. The biopsy shows subclinical antibody-mediated rejection. Patient is treated with rituximab and IVIG in the face of stable renal function. Cell-free DNA, which again was found retrospectively, was still high this whole time. They had a follow-up biopsy in 3 months per the clinical protocol. Again, the TruGraf is still abnormal, not TX. Biopsy still shows subclinical AMR. They're treated with additional rounds of intravenous immunoglobulin. Cell-free DNA now comes down. And by the 24-month time period, they got a normal biopsy with a TX TruGraf result. I think this is a great illustration of how both biomarkers can help track the course of a patient over time and inform interventions. Okay, I mentioned follow-up for treatment. So in the CTOT-8 trial, all patients that had subclinical rejection of either type had a follow-up biopsy at 8 weeks, and that's shown here. So here, all the patients at biopsy time point had subclinical rejection, either cellular or antibody-mediated. They all had blood sampling every 2 weeks at these intense monitoring visits, and then at 8 weeks, they had a biopsy. And what was surprising is after 8 weeks, only half the patients had resolved their rejection based on histology. More than half, 52%, still had ongoing rejection at the time, even though, again, these patients all have stable renal function. What we also found was interesting is if you look at the biomarker, which is the positive negative line is here, the groups that resolved their rejection shown here in red versus the group that had unresolved histologic rejection in black, a couple interesting things emerged. Number one is at the baseline biopsy, about half the patients who had resolved their rejection had a negative biomarker to begin with. And again, the biomarkers were done retrospectively. But almost all the patients that didn't have resolution of rejection had a positive biomarker at baseline. By the time treatment was done, again, most of the people that did not resolve still had a positive biomarker, where most of the patients that had resolution had a negative biomarker. So what this tells us is we can then monitor patients after treatment. I showed one example of that in the previous clinical example, how the biomarker can tell you whether a patient has had resolution or not of rejection after treatment. So how do we use this test, a monitoring algorithm? You have a lot of patients, and I think of this like a shepherd. You're shepherding your flock, and there are a lot of them. What do you do? How do you monitor them? How do you know what to do? So the TruGraf can help you decide what to do. So you do a TruGraf test on your stable patients, and many of them, about 2/3 to 3/4, are going to have a negative test. Those patients can simply be reassured and monitored without needing an invasive protocol biopsy. And again, as I hope you, not only do they spare a biopsy, but they also get that reassurance, which for patients is really important, to tell them you're doing okay. Then you can take the smaller group of patients, which are more manageable, and say, you've got an abnormal test result. We probably should do further evaluation, whether that's a biopsy or other testing or treatment, such as adjustment of immunosuppression, baseline immunosuppression. But at least you can focus your efforts on patients who need more of your attention and reassures those that are doing well. So in summary, subclinical rejection is common. About 1/3 of the patients have it in the first 2 years of their transplant. Was previously only detected by surveillance biopsies and is associated with inferior graft outcomes. Further episodes of rejection, development of de novo donor-specific antibodies, lower GFR, fibrosis, and graft loss. Monitoring with the TruGraf test can provide confidence that your patient's not having subclinical rejection and alleviate the need for invasive surveillance biopsies. And early detection of subclinical rejection and treatment improves outcomes. Thank you very much for your attention. I'd be happy to take any questions.
Thank you, Dr. Friedewald. Next, I would like to introduce Dr. Josh Levitsky. Dr. Levitsky is a professor of medicine and surgery in the Division of Gastroenterology and Hepatology at Northwestern School of Medicine. Today, Dr. Levitsky will share his presentation titled Biomarkers in Liver Transplantation, the Next Frontier. Welcome, Dr. Levitsky.
My name is Josh Levitsky. I'm a professor of medicine at Northwestern University Feinberg School of Medicine, and I'm a transplant hepatologist. And the title of my talk is Biomarkers in Liver Transplantation, the Next Frontier. So the tenet of this talk really is linked to how can we improve outcomes in liver transplant recipients. We know that long-term complications in liver transplant recipients are linked in part to immunosuppression therapy and its complications. So if we think about malignancy, nearly half of patients who have had a liver transplant develop some form of malignancy. And that includes skin cancer, but there's increased risk for other cancers, oropharyngeal, lung cancer, colon cancer, lymphomas, etc. Cardiovascular disease, most patients have some form of cardiovascular disease, from just hypertension to more significant like coronary artery disease or strokes. This is a significant problem in this population. Renal dysfunction, over time, most patients have some degree of renal dysfunction, chronic kidney disease. Infection is increased in these patients because of immunosuppression therapy. Most patients do have some type of drug side effects, particularly early after the transplant, but maybe long-term. And of course, these medications are costly to the patient and the healthcare system. So if you take all of the liver transplant complications, there is a linkage in all of these to immunosuppressive therapy. So it would be very nice to be able to minimize the toll of immunosuppressive therapy in our transplant recipients. The issue is, though, if immunosuppressive therapy is the problem, again, why can't we just minimize it and not worry much about developing rejection? We know from older data that rejection in liver transplant recipients may not be so harmful. Well, this is old data from the 1990s, and we have learned more recently from the post-MELD era that rejection may actually be detrimental to patient and graft survival. And so we performed a study which we looked at 2 cohorts, A2All and SRTR, and found that acute rejection, or actually the absence of acute rejection postoperatively, patients had the best survival, graft and patient survival. And this was sort of counter to data before the 2000s that rejection really didn't have a difference in survival compared to those with no rejection. So this shows that patients who have not had rejection, which is the gray line on the bottom, have the best survival. And the other lines are the timing of rejection. So in the first 6 months and 6 to 12 months, you can see an increase in mortality in all of these groups. And then after 12 months, the mortality or graft failure and patient death increased significantly. And so the question is, of course, is this all related to rejection and graft failure, or is this the immunosuppression required to reverse the rejection? Either way, it sort of doesn't matter, but because rejection really is something that we should be concerned about. And so just minimizing immunosuppression therapy and not worrying about rejection is really not an ideal approach and may increase complications for this patient population. And so really what we are trying to develop and have made some headway is to develop a way to monitor immunosuppression much better so that we can optimize it. The traditional holy grail is withdrawal of immunosuppression after transplant. But this is only possible in a small percentage of patients. It may be possible in a high percentage of patients who are a high percentage of select patients. But if you look at the overall patient population, we're looking at about 5 to 10%, particularly late after the transplant on minimal immunosuppression, and older patients would be able to be successfully withdrawn from immunosuppression. So this approach to withdraw immunosuppression completely doesn't apply to the vast majority of liver transplant recipients. Rather, we believe the other holy grail, or perhaps the most important one, is actually being able to monitor the immune system in the vast majority of patients. So having a biomarker that can predict acute rejection to allow one to modify immunosuppression, or predict complications of immunosuppression, particularly chronic kidney disease, would allow clinicians to modify therapy in advance and be able to augment or minimize immunosuppression in a safer way so that rejection is not occurring at a really high level when you're trying to do these interventions. I think it's important to think about biomarkers in terms of omics. And really, this is where the field has progressed significantly in the last 10 years, more in other organ transplants, but liver is catching up to this. And so some of the terminology is important. So we start with genetics, which is gene DNA. Then we move into genomics, which is RNA transcription. Much of the work has been done in this area. Then there's proteomics, which is the translation into proteins. And then there's metabolomics, which is modifications of proteins or metabolites. And these lead to a phenotype. So the phenotype is either healthy transplant without any rejection, or rejection, which is dysfunction, immune dysfunction of the transplant. It's really important that when you're thinking about biomarker discovery and validation, that you understand what this means in terms of correlating this with an actual clinical disease. So one could have a biomarker signature in the blood, but you have to tie it with a specific phenotype that the patient is experiencing so that you can develop biomarkers that really distinguish two disease processes. So rejection versus non-rejection, tolerance versus non-tolerant, kidney disease versus no kidney disease, response to therapy. So any biomarker signature really needs to be tied to a clinical phenotype to have any relevance. Then one needs to decide which compartment is most relevant to the patient and their organ transplant, and how easy is it to get that marker. So blood is very easy to get from patients, as well as urine, but things like graft where you do biopsies and perform tests on the graft, are less ideal for serial monitoring. And in liver transplantation, there's not many places that are doing serial biopsies or protocol biopsies. Then you have to decide which compartment in terms of cell versus plasma versus parenchyma. So this is really important, and it's got to be feasible for patient monitoring. Then once you have a discovery, you really need to have external validation in multi-center fashion to really prove that the biomarker works in the transplant environment in multiple settings, multiple immunosuppression regimens, multiple centers. So let's talk about liver transplantation in of itself. The real balance here is this scale, which is we want to find a level of immunosuppression that is appropriately balancing the absence of rejection and also the absence of complications, such as chronic kidney disease. And so this is really the balance that we all try to achieve, and it's very difficult to do in clinical practice. And so we hope that biomarker research is able to balance these two and identifying over and under immunosuppression in a better way than we can clinically. So let's first talk about the rejection side and tolerance side. And this is a long list. I won't go through each one of these, but the field has really evolved over the last several years in detecting biomarkers of liver transplant rejection. You look at most of these from the top half here are on DNA or sort of genetic markers of risk of rejection. Those may predict a risk, but they're not too helpful in serial monitoring. As we look at the bottom here, there's been a number of studies, including ours and other investigators, that have really looked at RNA expression, either microRNA or mRNA or proteins in the blood that can help distinguish acute rejection from healthy transplant or other types of graft dysfunction that are not rejection. So biliary problems, NASH recurrence, things like that that are not rejection, that can be helpful in the management of patients. So I want to talk about our CTOT study and our effort at Northwestern to develop a biomarker of rejection that can be used in the peripheral blood to monitor patients. And the CTOT 14 study, which has long been completed, but we've had a number of publications come from this study, was a prospective NIAID study collecting samples from liver transplant recipients in 202 recipients at 7 centers. And we at least had a year follow-up on these patients, and we collected samples serially. And our two goals were to identify signatures of acute rejection and chronic kidney disease so that we could perhaps predict these events and develop biomarkers to be used in that fashion. And so the long and short is that we recently had a publication where we had a Northwestern discovery cohort that was differentiated by acute rejection versus healthy transplant. We were able to develop a mRNA blood gene expression signature for acute rejection that had very high accuracy in distinguishing rejection from healthy transplant. And of course, we needed to validate this in the CTOT 14 study in a multi-center fashion. As I mentioned before, this external validation is quite important. And we were able to show relatively good validation, accuracy of 0.77. What you will note is that the negative predictive value is really what is optimal here. So this appears to be a very good rule out rejection test. Not great at ruling in rejection, but ruling out. And this may be important for rule out rejection when one is minimizing immunosuppression, to suggest to continue minimizing immunosuppression if you have a strong rule out test. And this is also evidenced by our serial analysis in this study, where you can see the gene expression scores slowly increase before an acute rejection episode. And this dotted line is the threshold cutoff for the gene expression test, above which is rejection and below which is TX, which is healthy transplant or transplant excellence. And as you can see, the score increases before acute rejection and goes down over time with TX, with healthy transplant. And this is just standard management of patients. This is not immunosuppression minimization. And you can see that they split about 90 days before the rejection episode or the time point of 6 months post-transplant. We also see this in non-AR, so we included patients with TX, which is healthy transplant, and also other forms of graft dysfunction that were not rejection. And you can see that similar split before that. Really, we're not seeing these rejection expression signatures in a healthy or non-rejecting cohort. The other part is we did treat patients, a cohort with, in the study, patients got treated for acute rejection. And as you can see here, the post gene expression score goes down after treatment, which is really what you want to see. But it takes a long time. It takes a long time for that to resolve. It's very interesting that it goes up and down with before and after with treatment. It supports the validity of this assay. The other thing you may wonder, this was a 36 gene model, this AR versus TX model that I'm talking about. And what you can see is that the vast majority of genes, these are just in the peripheral blood, are in the liver pathways. So liver hyperplasia, hyperproliferation associated with acute rejection. And we hypothesize that this is a response, an immunological response in the liver itself, or liver regeneration attempts that sort of signify this gene expression. We've also investigated proteoforms of acute rejection, which are modified proteins using a top-down proteomics approach that we have here at Northwestern. And we're currently in the phase of discovering more and trying to validate more in a number of these samples. But some of these proteoforms are elevated in acute rejection compared to TX, and also compared to ADNR, which is dysfunction without rejection, that cohort. And you can see that there are differences. So we're very interested in proteoforms or proteins that are a result of gene expression changes that occur in acute rejection or TX. Next, moving on to tolerance. This is actually sort of the opposite of rejection, and there have been investigators that have looked at blood and graft gene expression signatures that we see in patients before they're weaned off immunosuppression that can perhaps predict the ability to achieve tolerance or full immunosuppression withdrawal. And there is some suggestion in the blood, but it appears that in the graft itself, there are gene expression signs that correlate with the ability to wean immunosuppression fully. And these are being validated in other studies, intolerance studies. We performed a study where we withdrew a small cohort of patients off mTOR inhibitors because they may have immunoregulatory properties or tolerogenic properties. And we found a PBMC profile that appeared to, before withdrawal, that appeared to predict the ability to achieve tolerance. So tolerogenic dendritic cells up here, to some degree Tregs, regulatory B cells were higher. We also looked at biopsy gene expression, and we used the same gene signature that was shown in that prior study, in our study, and it was a good predictor of the ability to achieve tolerance, which is really kind of exciting, that it would validate it in an mTOR cohort where the previous was a CNI cohort. So as we're developing these tests for rejection and monitoring, and I should mention that the rejection, that the AR versus TX36 gene model is being licensed by Transplant Genomics as TruGraf liver. And where there is a TruGraf kidney that is used for monitoring of kidney recipients, and we're developing TruGraf liver for similar purpose, serial monitoring to manage immunosuppression and perhaps immunosuppression minimization. But we're also interested in the other spectrum, which is chronic kidney disease. And you could use some of these tests together to predict patients who are at risk for over-immunosuppression to minimize patients with the use of the gene expression tests. And what we're really trying to do is achieve this balance. So we sought to look at proteins in the blood that could be detected in patients who have chronic kidney disease. And we did this early on, nearly 10 years ago, a kidney multi-analyte profile where we tested 16 renal injury proteins in liver transplant recipients that had chronic kidney disease versus those who did not, just as an initial discovery. And we found a series of proteins here on the upper left, and on the bottom, the prediction and the correlation between GFR at the time of CKD. And these are renal injury proteins. But we realized that this was probably no better than just a serum creatinine, because this is just showing that these proteins are elevated at the time of CKD, which is already established. It would be more valuable to be able to predict future CKD. So are these proteins present in the blood when the renal function is normal, and can that predict deterioration and renal dysfunction? And so one of our other goals of CTOT14 was to look at the serial change in these proteins over time in patients who had two different trajectories, those who had maintained renal function versus those who deteriorated. So we had a cohort of patients who had normal renal function at month 3 and were followed over time in this study to 1 to 2 years. And you can see here, the black lines up here are the preserved renal group. So they did not really have, they were within a 10% decline, but the vast majority had stabilization of GFR over this time period, where the red group was those who deteriorated over time. And what we did is we tested the protein panels at baseline at 3 months, and also tested them at each time point serially over the course of these patients post-transplant, and looked at these proteins over time, see if they correlated with GFR. And we were able to publish this recently in Hepatology. And what we developed is a model at 3 months post-transplant that included 2 markers, beta-2 microglobulin and CD40, and hepatitis C. And this worked well in hepatitis C, non-hepatitis C patients, or those who had cleared it. And we developed a model called PRESERVE, which is prediction of renal outcomes after liver transplant. It has a certain formula here. You can get these 2 protein levels and put in the clinical hep C or no hep C. And we were able to show in CTOT14 that it had a good prediction of detecting renal preservation versus renal deterioration. So if these proteins were elevated, there was a much higher risk of developing renal deterioration. Again, these are patients who started out with normal renal function and have this PRESERVE positive test at the time when the renal function is normal at 3 months. So could be very helpful to identify a higher renal risk population to consider something like CNI minimization. And in this, we collaborated with Baylor University, who had a large biorepository, and we did a very similar study within their biorepository, matching up the patient characteristics to CTOT14. And we were able to validate the PRESERVE model in a separate cohort of Baylor University transplant patients, which is nice to see that we didn't just see this in the CTOT14 multi-center study, but we also saw this in a separate liver transplant center. Interestingly, we also saw that these proteins, not just beta-2 microglobulin, increased over time with GFR deterioration. So as you can see here, this is the GFR, for instance, beta-2 microglobulin. As time goes on, as GFR is getting worse, you have increasing levels of beta-2 microglobulin, as well as these other proteins, alpha-1 microglobulin, cystatin C, etc. So there's correlation with these levels with GFR deterioration. And we also, just as an aside, have been interested in pre-transplant prediction of recovery after a liver transplant alone. This is different than the post-liver transplant environment. They're not on immunosuppression, but as everyone knows, the patients getting liver transplanted often have renal dysfunction. It's part of the MELD score. And we're often wondering how we can predict if they're going to recover their renal function after transplant or not. And if we could predict it, we would continue with a liver transplant alone. And if they were predicted to have irreversible kidney injury, then one may consider a combined liver kidney transplant, and it may help in the selection process. And we were able to identify two kidney markers, osteopontin and TIMP1, or two plasma proteins that were much higher in patients with reversible acute kidney injury. So these appear to be protective proteins rather than related to kidney injury. This was our initial study done only at Northwestern, and we developed a model that, along with age and diabetes, so absence or younger age, absence of diabetes, and elevation in OPN and TIMP1 can predict reversible acute kidney injury with reasonable accuracy after a liver transplant alone. And we define that by reversal of their GFR, lowering at transplant to greater than 50 to 60 at 1 to 3 months after transplant. And so, of course, that was just our Northwestern patients, but we also paired up with Baylor and did the same thing. We looked at their cohort in serum, and also were able to validate this test, which is called the reverse test, or renal recovery assessment at liver transplant. So it's a model rather than a test. So it has these two proteins, age and diabetes. You can see here that this was also quite predictive in a separate validation cohort. So just in summary, most of this work has occurred in the post-liver transplant environment. And really what we want to do now is take biomarker validation, and we validated some of these biomarkers and take it into clinical practice in liver transplantation. So the TruGraf liver, which is the 36 gene expression test in the blood, we're developing this for prediction of rejection and also healthy transplant. And we have strong interest in studies and grants to minimize immunosuppression and use the blood marker to guide this. But it's certainly the development of this really is focused on being able to use it to minimize immunosuppression with the security that the patient has no evidence of rejection in the blood as you're minimizing immunosuppression. Certainly, we're interested in developing these proteoforms I talked about, and also we're in the process of looking at cell-free DNA in liver to maybe add to TruGraf liver for detection of rejection, maybe even enhance the AR versus non-AR profile so that we can best manage patients. Certainly, there's a lot of development in immune quiescence and tolerance that I mentioned before, and also in pre and post liver transplant kidney disease with the markers I mentioned, predicting reversibility of renal function at the time of liver transplant, and then really preserve in identifying patients at risk for chronic kidney disease after liver transplant. The idea may be to be able to use, as the bottom here shows, the markers together, preserve and TruGraf liver, to identify patients who really need minimization. Those who are going to develop chronic kidney disease could be minimized with the help of TruGraf liver to detect rejection if you're minimizing too much, and use it to achieve the endpoint of really improving their kidney outcomes. Whereas some patients may not have a risk of developing chronic kidney disease, and we all know that there is a cohort percentage of liver transplant patients that may not have renal risk. And the PRESERVE test may be able to identify that, where you may want to continue their current immunosuppression regimen and not minimize them. So this is all very exciting, and I hope you enjoyed the talk. This is my email, and feel free to email me if you have any questions. Thank you.
Thank you, Dr. Levitsky, for that insightful presentation. Next, we will hear from Dr. Saif Muhsin. Dr. Muhsin is a transplant nephrologist at Brigham and Women's Hospital. He is presenting an introduction to new study data utilizing donor-derived cell-free DNA as a reliable measurement for the effectiveness of treatment for patients with biopsy-proven antibody-mediated rejection. Welcome, Dr. Muhsin.
Good afternoon. I'm Saif Muhsin from the Brigham and Women's Hospital, and I'll be talking today about the use of donor-derived cell-free DNA for monitoring of acute kidney allograft rejection treatment response. I have no disclosures to declare. So this is a figure from an observational study in CJSON, comparing different induction and maintenance anti-rejection agents. All of these groups had an incidence of acute kidney allograft rejection around 10% within the first year after kidney transplantation. This is an older study that looked at the effect of acute rejection in a different era on allograft failure. The relative risk of chronic allograft failure was significantly higher in the rejection group versus the no acute rejection group. This is another more recent study showing allograft survival in relation to time of first treated acute rejection episodes during the first year after transplant. So here they only included the transplants that were functioning at for at least 1 year, and they assessed up to 4 years of allograft survival, and they showed a significant reduction in allograft survival for all the rejection groups. So we know that acute rejection is a major cause of allograft dysfunction. It's associated with worse allograft survival, and we've really gotten better over the years in the way we treat rejection as we increased our arsenal of anti-rejection agents. But we haven't really made much progress in monitoring the response to treatment. Histopathological examination of a kidney allograft biopsy is currently the gold standard for diagnosing acute rejection, but this is associated with multiple complications, including bleeding, infection, and even allograft dysfunction and loss in rare circumstances. There's a lot of time invested in scheduling and performing biopsies, and the person power required is significant. And there are also issues concerning the cost, especially if we want to monitor the response to treatment. So there's an unmet need for less invasive and affordable biomarkers to track the response to treatment of rejection. So this is where cell-free DNA can come into play. And cell-free DNA is basically fragmented donor DNA. It's in the recipient's blood, and it originates from cells undergoing injury or death. It increases in blood after allograft injury, and then levels above 1% in the blood have been associated with acute rejection. This figure is from a study by Roy Bloom and colleagues that was published in JSON. So it shows the pathologists' diagnostic findings for 107 clinically indicated biopsies that had matched plasma donor-derived cell-free DNA levels. All these visits had donor-derived cell-free DNA samples that were collected at the same time that a clinically indicated biopsy was performed. So there were 27 patients with 27 samples with active rejection, and there were 75 patients with 80 samples with no active rejection. They were rank ordered and color-coded by donor-derived cell-free DNA levels, so that the highest cell-free DNA levels are on the far right on the x-axis. White here on the plot indicates that the element was not associated with that biopsy visit. For example, this visit or patient here was not associated with an elevated DSA because this box is white right here. For each sample on the x-axis, the associated elements on the y-axis are shown as a colored box by the level of cell-free DNA associated with that sample. And as I said, the highest donor-derived cell-free DNA levels are in red, and the lowest are in are in blue. And the vertical dashed line here is at the 1% cutoff that we mentioned. The p-value of association of cell-free DNA above 1% with each element is shown right next to the element right here. And as you can see, patients with antibody-mediated rejection had significantly higher cell-free DNA levels, while patients with T-cell mediated rejection had a significantly higher cell-free DNA level only when they had more severe rejection. This is a figure from the same study comparing cell-free DNA to serum creatinine levels in 27 patients with and 80 patients without active rejection. So in the first figure here, the horizontal line in the box and whisker plots represents the median, and the bottom and the top of the box represent the 25th and the 75th percentile respectively, and the dots are in the individual results. The median cell-free DNA in active rejection was statistically higher at 1.6% versus a 0.3% for the no rejection group. And you can see serum creatinine was all over the place. These are the ROC curves for both the cell-free DNA and the creatinine, and it showed an AUC of 0.74 for cell-free DNA versus a 0.54 for serum creatinine. This graph here shows the sensitivity and specificity of 59 and 85% respectively, and the graph over here shows a positive predictive value and a negative predictive value of 61 and 84% respectively for cell-free DNA to discriminate the active rejection from no active rejection. This is another graph from the same study, and that looks at basically cell-free DNA in discriminating antibody-mediated rejection. And the same basically box and whisker plots that show the 25th, 75th percentile and the median here in the middle, and the dots represent the individual basically data points. The cell-free DNA had a higher median at 2.9% versus our 0.29 for the no rejection group. And then again, serum creatinine was all over the place. The ROC curves showed an AUC of 0.87 for the cell-free DNA versus a 0.57 for serum creatinine. This graph shows the sensitivity and specificity of 81 and 83% respectively, and this one shows a positive predictive value and negative predictive value of 44 and 96% respectively. So we're practically limited in the number of allograft biopsies we can perform due to risk of complications, expenses, and patient inconvenience. So we hypothesized that given the short half-life of donor-derived cell-free DNA, which is about 30 minutes, we think that if patients with acute rejection were treated appropriately, then the levels of donor-derived cell-free DNA would basically could verify a resolution of rejection as early as the final couple of days of treatment. So our objectives are to use the VeriCord track in biopsy-proven episodes of acute rejection with the aim to track the trend of donor-derived cell-free DNA to monitor the response to treatment and recovery. I'm sharing this slide from this is a face transplant patient, and this is the slide basically represents the clinical course in our hospital. This patient had basically multiple antibody-mediated rejections, and there were a total of 9 biopsies over the course of 5 months. And that's about a biopsy every 2 weeks. So imagine if we could do this for the kidney, like how more informed our treatment decisions would be. Unfortunately, this would not be practical or realistic for the kidney world, as we mentioned. We really need to investigate rejection biomarkers that will give us an idea about the response to our treatment. And this is where cell-free DNA could come into play again, and that's why we're doing this study. This is our protocol. So our inclusion criteria, basically all-comer adults with kidney transplants with symptoms and signs of allograft rejection. We'll be excluding patients with multi-organ transplants, patients who received the kidney from their identical twin, patients with who received bone marrow transplants, pregnant patients, and also subjects participating in other cell-free DNA studies. The estimated duration of the study is 1 year, and we'll be aiming to enroll 6 to 10 subjects over that period of time. These are my references, and thank you.
Thank you, Dr. Muhsin. This concludes today's presentations. At this time, we would like to invite any questions from our audience to any of our presenters. Thank you for joining us today. This concludes today's presentation. Have a good day.